Good evening, everybody. You're once again most welcome to the Neuratorium Educational Series, which is a series of peer-led training to enhance neuroscience knowledge among Ugandan medical professionals, including psychiatrists, psychiatry trainees, medical students, nurses, psychiatric clinical officers, and other interested participants. You're all most welcome to this week's edition. I am Mugume Raymond, your moderator, a psychiatry resident at Makerere University in my final year. And this week, we shall be looking at Parkinson's disease. This is week 6. We have had a series. I'm sure many of you have been part. You are most welcome. Our trainer today, the Neuratorium trainee, who is going to lead us in the discussion is Dr. Mugume Raymond. He's already on the call. Today, we shall look at, he'll take us through the definitions, the epidemiology of Parkinson's disease. It will be an introduction to Parkinson's disease, which he'll go deeper in tomorrow. So you are most welcome. Over to you, Dr. Mugume.
Yes, good evening, friends. I hope you managed to move, as the slogan of these days. Thank you for the good introduction, Dr. Kembelembe. And today's topic is about Parkinson's disease, and we are going to just understand the originality of how Parkinson came to be known as Parkinson's disease, and what is the picture like globally, and what are we supposed to know when we are looking out for this condition. First, Parkinson has Dr. James Parkinson, who was a surgeon in London, observed several patients who presented with almost the same symptoms despite their individuality. And he then called it paralysis agitans, which literally means shaking palsy. And this was in 1817. What he observed is that these patients, in their presentation, they had involuntary tremors with the loss of or reduced speed of movement in the different parts of the body. He also realized that most of them needed stimulating drugs to pass stool, because they had developed constipation. He also observed that most of them had sleep disturbances, and although he did not think that Parkinson as Parkinson was did affect the mind of the individuals. But then another gentleman called Jean Martin Charcot refined that. He said that actually these people, as much as they did have these symptoms of tremors, sleep disturbances, they had constipation, they also had psychiatric symptoms. And so he went on again to differentiate between tremors that are due to Parkinson's disease, and then tremors that are due to multiple sclerosis. And before we knew it, he also went on to find exactly what would be the underlying cause of why do people develop Parkinson's. And he went in 1895, he did an autopsy of a patient who had died of similar symptoms of Parkinson, and he concluded that maybe a particular part within the striatum, which usually has the putamen and the caudate nucleus, had an issue. And he did well observe that the substantia nigra, which usually has neurons of dopamine, was most implicated in this case. I also observed that earlier in the patients, they had difficulty doing the ordinary activities, and also said that the more the disease progressed, the more slower they were to execute movement to go on. So some of the definitions that we'll find in our clinical practice or in our conversations when we talk about Parkinson's, or when you find a circle of people, is the on and off. The on time is usually the period of good motor symptom control after a patient has taken their medication and it is working well. Then the off time is usually you have poor motor symptom control, because as we shall see, is that this disease has both motor symptoms and non-motor symptoms. So on and off, you're looking at literally the motor symptom control. If people, their tremors, their dyskinesias, as we shall look at on. Then the wearing off is usually when the drug has weared off. So you have recurrence of symptoms before the next dose of before the next scheduled dose. So usually the patients have recurrence of both motor and non-motor symptoms. And we shall see usually in treatment, as we shall see, just to give you a snipnet, is that usually we use levodopa. So before the next dose of levodopa, you have wearing off, which is usually recurrence of motor and non-motor symptoms. And usually this wearing off usually resolves after you've given the next dose in 15 to 45 minutes of levodopa administration. We also talk about dyskinesias. We know that this word has come a long time, but usually we mean involuntary movements. And in Parkinson's disease, they range from chorea, which affects the limbs and the trach, looked at fixed dystonic postures, and then in rare cases, myoclonus and Ballism. However, there are what we call troublesome dyskinesias. These ones usually are very painful. They impair balance. Someone has a gait impairment, and sometimes they're so excessive to the point of causing coordination impairment or general functionality of the patient. There are some of the cardinal symptoms that we need to know when we talk about Parkinson's disease, and these are the major four. We have bradykinesia, we have rigidity. We shall look at those in a little bit of detail. We have resting tremors, and we have gait impairment or postural instability. And we should keep in mind that not all these four symptoms, you will see them in every patient who has what? Who has Parkinson's disease, and neither do they present early. All of them present early in the condition of the patient. And so when we talk about, sometimes when we talk about Parkinson's disease and Parkinsonism, Parkinsonism is just a clinical syndrome. That a syndrome is where you have a lot of symptoms, but then you cannot per se describe where they are coming from or what is the cause. But once you give, in a patient has that clinical syndrome and they respond to levodopa, that is when now we change from Parkinsonism to Parkinson's disease because of their response to levodopa therapy. So let's look at the motor symptoms. Bradykinesia literally means slowness of movement. Then we have akinesia, which is lack of movement. And then we have hypokinesia, which is poverty of movement. And bradykinesia is a very cardinal symptom. It was first observed by Charcot in 1879 after Dr. James Parkinson had described the shaking palsy, and it is a major cause of disability in most of our patients. And it manifests in many ways because, again, it is slowness in the movement. You can start saying how people write, like the micrographia. Usually a person used to write eligible, readable letters, but now they write very small letters. As you can see here, and then you have difficulty swallowing. You have a softer voice. Maybe they used to speak audibly, a good voice like mine, but then they have a more softer voice. They hardly express their facial muscle. They have a decreased facial expression, which is hypomimia. And then again, like I said, amplitude repetitive movements goes on increasing. So if you tell them to touch their ring finger to the nose, usually that speed is usually very reduced. Then we have what we call then we have what we call muscular rigidity. This is resistance to movement. And at the beginning, it is cogwheel, where you have like rhythmic brief, there are brief increases in resistance during passive movement. And this kind of movement combined with it's usually, this rigidity is usually combined with a tremor, okay? So like, if you have known a cogwheel, the best example would be there are these, I don't know how they call them, but a gari, I don't know how they call those ones in English. Then we have lead pipe rigidity, where someone can be very stiff the whole body with no almost no range of motion, and it affects the arms, the neck, and the legs. But also the back can be involved. When the back gets involved, usually a person has like a stooped appearance, as we shall see in one of the diagrams. And most patients will always be complaining about difficulties turning in bed, raising from the chair because, again, of that stooped appearance, or because of that rigidity that they experience. We have resting tremors, where you have a person, when they sit, they are not doing any activity. They have those involuntary oscillating movements within their hands majorly. But once they hold something, that resting tremor goes away. Then the peel rolling, their hands, their finger nails, usually they feel like as if they are rolling a pill. That is the kind of tremor they do have. They are as if rubbing movements between the thumb and the index finger. And they're usually relieved by purposeful active movement. So if you give them something to hold, or if they walk, if they touch somewhere, those movements kind of as if they are off. And the other thing that we need to know with this is that it is the most common presenting feature in Parkinson's disease. Uh, Everywhere you look around, you will have that pill rolling tremor or resting tremors, and sometimes that tells you that this patient most likely has PD. And these tremors develop in 20% of the population. No, they never present, but 70% they will have. And they usually affect the hand first before they can affect the lower limbs and the jaw. So this is the stooping posture in this gentleman here, when the back has been involved in that rigidity. So one of the things that we know tonight, this is the fourth, of course, cardinal, and they lose posture reflexes. They also sometimes, because of this instability, they can fall down, and usually it is almost one of those last cardinal features that will present in a patient. So it helps to differentiate, other forms of Parkinsonism, where it might be an early future, as we shall see in the next phase. So in patients with Parkinson's, walking is usually very, very affected. They have that gait impairment. They have slow, small steps when they are walking. And when you ask them to turn around, it will be very slow, or they might make multiple small steps before they can really turn around. That is what we need to know. Then we have terms like festination, which usually are fast succession of steps with the patient. At times, you're only able to stop at an obstacle, but it's as if you're shifting from walking to running until an object is in front of you, then they can stop. That is what we need to know about the gait impairment. The gene of Parkinson's disease is quite a complicated one, and we still seek knowledge. The research is still going on. What we so far know is that within the brain, a cell, within the cell, the disorder or the problem starts within a cell. As you can see, like this is the cell, but this is where the problem starts. And then from one cell, you have cell to cell. Like in this case, you have two cells, so long as they are within close proximity of each other. And then ultimately, in the later stages, you have the whole brain region being involved. So what does that mean is that the progression of Parkinson's disease pathology happens at different levels, okay? We have within the cell, we have between cell, from cell to cell, and then within the whole brain level before you can actually see the clinical symptoms. So if a patient comes and then they are saying that they have been having this constipation, don't just give loperamide. Maybe one might want to investigate and do a thorough history. That is the journey of Parkinson's. So as you're seeing the end stage of it, you keep in mind that there are different levels at which the pathology is happening for each patient. And we also need to recognize what we call the Brack stage, which kind of gives us what we see with patients who have Parkinson's disease and their symptoms, okay? In the first stage, as you can see here, it is the first stage usually starts with the dorsimotor X nucleus, which is the nucleus of the vagus nerve, and usually this usually affects the GIT, and so most patients will present with constipation as the first symptom of Parkinson's disease. Okay, and that is from the Brack stage. And as you can see, it takes years to get to the sixth stage. Then in the second stage, you have the gain setting nuclei, which is here literally you start to see some of the motor movements or the motor symptoms coming in, the p-rolling tremors, the resting tremors, start to show up, but this again takes some years. They say about 15, you can take about 15 years before you can actually start manifesting the second stage or to the third stage, to the fourth. So between the first and the second stage, usually about 15 years. Then you have the substantia nigra, which is in the third stage here. This is where now you have loss of dopamine neurons in the substantia nigra. And so the patient then starts to present with these other dyskinesias that we talked about. The cogwheel rigidity comes in because, again, we are talking about the striatum, which is really always about the fine movements are being affected. And then we have the mesocortex and the thalamus, which is in the stage 4. You remember the mesocortical pathway that we talked about, which usually is um, from the cortex and then to the around the amygdala and the VT, the ventrotegmental area, and the cortex. That also starts to get involved in the stage 4. So they start to manifest with neuropsychiatric symptoms. But earlier in the stage, you might have them having sleep disturbances. And so this might be more pronounced in stage 4. And then you have stage 5, where you have the higher order centers being involved. That is now the motor area. This is usually the motor area that is usually very affected. And then we have both now the neocortex, where both the primary motor center and the secondary motor center are all involved in that stage. So the pre-symptomatic phase, like I said, as we shall see tomorrow in the neurobiology, we have there are some Lewy bodies that are usually aggregated in some of the areas of the brain. And usually these people, as much as they might not be symptomatic, like I've said in stage 1, the pathology is already happening, okay? Until you see the motor symptoms, usually you know that stage is very advanced. Some of the clinical symptoms and the time, of course, we need to keep in mind is that I've talked about motor symptoms and non-motor symptoms. And usually in the prodromal, we might not get any motor symptoms, and this is where we at. Let me just use this laser pointer. Here, as you can see, you might not have any motor symptoms in the prodromal stage of the PD. However, what you will observe in the non-motor symptom, you will see a person excessively sleeping during the day. They are anxious, and those are psychiatric manifestations meanwhile. Then, of course, the dorsal of the vagus nerve is included, and then so they are presenting with constipation. You're giving stimulating drugs to help them with that. Then they have REM. You find that they are doing, like, they don't remember that there is some actions they did while they were in the REM sleep. Okay, so they have the REM sleep behavior disorder. They wake up, they are beating people, they commit murder, or so during this REM sleep behavior disorder. And some of them might actually also have depression and hypsomnia, okay? So these are some of the symptoms in the non-motor symptoms. As we go on in the early stage, we start to see the bradykinesia, the rigidity, whether cogwheel or lead pipe, and then the tremors, whether fine or peel rolling. These will all be in the early stage. But remember that as this is happening, we need to keep in mind of the different levels from within the cell, and then all the cells within the brain. Then in the non-motor, they are feeling fatigued. They don't have any facial expressions. They start to be forgetful about the minor things like names, where they put their money, where they put their keys. If the stockings, how they are wearing the stockings, maybe one is blue, another one is red, the shoe as well, and then they start to complain as well of pain. And then in the mid stage, we have orthostatic hypotension, because again, like I said, when the brain is starting to get involved, almost all areas start to be realized, like the nerves are all affected. So you have orthostatic hypotension coming in, and then you don't know if it is the drug or if it is the age, because most of our patients are usually above the age of 60. Then urinary symptoms, their micturition habits they cannot micturate very well. Maybe they will now start to depend on the urinary catheter bag. Then axial deformities, of course, where you have the gait impairment coming in, the dyskinesias, these are involuntary movements coming in, and then the fluctuations in terms of speed, in terms of how they walk, in terms of control of their movement coming in. And then the late stage, they will have falls, then they will have maybe broken bones, and then they will have to go in for theater. They have these gait disorders. They cannot swallow. They have difficulty swallowing. And in the non-motor, you have dementia coming in, and then psychotic symptoms of hallucinations, hearing voices that other people don't see, and delusions start to come in. So this is why it is important that we are having this discussion. Some of the non-motor symptoms, of course, just to again emphasize, we have the neuropsychiatric, we have depression, inability to feel pleasure, apathy, we have anxiety. This is really with pleasure. We have cognitive dysfunction, impairment coming in, confusion, dementia, hallucinations and delusions, and then some impulsive, compulsive behaviors also come in. And then the loss of smell is also very prominent. And pain. Pain can either cause you the neuropsychiatric conditions, or but it should be noted. Then we have sleep disorders, which usually come early in the stage, daytime sleepiness and sleep attacks. We talked about the REM sleep behavior disorders coming in, and then at night they can hardly sleep, okay? Then autonomic function, one of the most we need to always know about is constipation. Then urogenital dysfunction, they cannot control their bladders. They have difficulty actually micturating as well, orthostatic hypotension, which is usually the sudden drop of blood pressure, difficulty swallowing, and then sexual dysfunction also come in. And all these symptoms really impact the patient's quality of life at different levels. One might come with just constipation and insomnia, but then you see that the family and the patient themselves are really distressed. Uh, Time course of this, I've told you that I've shared with you that between the prodromal stage and the prodromal, which is really like the first stage, the second stage, you need about 15 plus years, okay? So constipation is usually the first thing that will present in these patients. Then you have the REM sleep behavior disorders coming in, and then loss of smell, depression follow before you can make the diagnosis of what? Parkinson's. And usually you will have already, maybe they will even come in late, maybe they are usually advanced with pain, fatigue, the myoclonus, the bradykinesia, rigidity, all coming in, and then you have these fluctuations of dyskinesia, these involuntary movements, whether they are painful or not, that becomes a distinction. But by this time, these are usually complications, and these are usually motor symptoms, and these are the non-motor symptoms. But it takes years before, about 20 years to actually, from the first symptom of constipation to that, 15 to 20 years to make the diagnosis properly. Epidemiologically is that Parkinson's disease is now a well-recognized neurodegenerative disorder, and it is also within DSM-5, among others. It affects about 6 million people worldwide, and in Europe, it is estimated that 1.2 million people have Parkinson's. That is, it affects about 1 to 2 per 100,000 of the population. So it means that we need to be very keen. It affects people are over the age of 60 years, but it's starting to also manifest in individuals who are younger than 50 years, and we shall see why. And it is estimated that this prevalence of Parkinson's disease will continue rising in the coming years. It rises with the age, and usually most common in the oldest age groups. But what we need to know is that as the as of in this literature, they say that men are more affected than women, and we are still yet to know maybe there are confounding factors. But in Asia, South America, Europe, about 1,134 per 100 people are usually affected. And the prediction is that the prevalence of Parkinson's disease will continue rising, especially within our age group, within the years of age. As the world continues to grow older and older, we see that Parkinson's disease will be prevalent. So it is only prudent that we are equipped with wisdom and knowledge. Some of the risk factors associated is that there must be a balance between the positive and the negative factors on the genetic predisposition of an individual. So these are the risk factors. The age is that you must be above 60 years, okay? Although some below 50, we are starting to see that. Sex, men are more affected by, and genetics, you must have maybe a history that you have Parkinson's disease in your family. Maybe farmers are usually more affected within our settings, some that I've seen. Those who use dairy products, history of melanoma, that is a type of cancer, and then those who have sustained traumatic brain injuries, so they need to be followed up because the likelihood of them getting Parkinson's disease is high. And then some of the other factors that are, of course, are usually very debatable is tobacco smoke, or tobacco smoking is seen as a protective factor, but then it also has other other problems, as you know. Then caffeine, physical activity. If a person using physical activity, NSAIDs have been mentioned to be protective as well, and calcium channel blockers. So these protective factors, vis-a-vis risk factors, have to be working. There has to be balance for the predisposition of this individual. So those are some of the things that we usually want to ask about: if they have smoked, used caffeine, their age, genetics, pesticide exposure within our settings, using dairy products, among others. How do you diagnose? Usually, there is no laboratory test that you will do to help you, except making a thorough history and follow-up of the patient. Like I said, usually the onset, when you look at the motor, you don't have any motor symptoms, but the non-motor, you already have like sleep disturbances. They tell you about the patient waking up at night and beating people, and they do not remember what they did while they were in the REM sleep. Then they talk about maybe they are depressed. They talk about their their sleep problems as well. Then the constipation. So it will take 10 to 15 years before you can make you can see the cardinal symptom presentation and make the diagnosis, okay? And then it takes almost a year to make that diagnosis and make a prescription, almost from the prodromal phase that we saw, but they had those non-motor symptoms. And then after prescription to between 1 to 5 years, you have that honeymoon, okay? They are on treatment, they are maybe adherent. Some will, when they see the symptoms, the motor symptoms have resolved, they might not come in for treatment. But then along the way, 4 to 6 years, after 5 years, you start seeing like advanced or mid-stage problems. They are starting to forget, they are starting to have those pre-rolling tremors, they are wearing off, the dose maybe is not enough. And again, because again, the pathology is coming in, and then you have these non-dopaminergic symptoms before death comes in. The non-dopaminergic is you have orthostatic hypotension, you have, apart from that, you have the dyskinesias, you have the hallucinations, delusions coming in, okay? This takes about 5 to 7 years for these non-dopaminergic symptoms to come in, okay? So most of these early symptoms present up to 90% in a subtle fashion, like I've already explained. The motor symptoms define the stages of Parkinson's disease, okay? We have the early, where you have untreated of mild to moderate motor symptoms, but if treated well, you will control them satisfactorily, okay? So that will be the early stage, okay? So the patient comes in, they have sleep disturbances, REM, they have constipation in your clinical acumen. You're like, this could be maybe, let me just give a small dose of what? Levodopa. And maybe the symptoms, the patient no longer has the constipation, the behavior is okay. Then maybe the fine tremors that had started little, they are well managed. Mild is now the mid stage is where now you have the other bradykinesia, the rigidity. If they are well treated again, you control the motor symptoms, you will have early response to the fluctuations that we talked about earlier on. And then in the late is that you have fully established motor complications, okay? The dyskinesia and the fluctuations, and then the non-motor and the motor complications that we talked about. So what we need to know is that dopaminergic treatment is highly effective in controlling our motor symptoms, but that will be for tomorrow or on Thursday. The causes of secondary Parkinsonism, apart from the loss of neurons in the substantia nigra, we have infections like encephalitis, the prion disease, neurosyphilis, toxoplasmosis. So you have to have some differentials. Carbon monoxide can give you that, cyanide poisoning, the manganese, and then solvents can also give you Parkinsonism. Drug-induced, to have dopamine receptor blockers like our antipsychotics they can give you that. The classic neuroleptics, like atypical antipsychotics also have been mentioned, then the dopamine depleting drugs and other drugs really, the antibiotics inclusive, the chemotherapeutic drugs, all those. Brain tumors, especially the supratentorial and the brainstem tumors, as well as intravenous malformations. Cranial trauma, of course, we talk about the subdural hematomas, the midbrain tumors. This one is really with the traumatic brain injuries. Metabolic, we have the hypoxia that usually happens with children, but also which can happen maybe if person was found in a not well ventilated area. Hypoparathyroidism, familial basal ganglia calcification, chronic liver disease, Wilson disease. As Wilson disease is usually accumulation of copper because the chelation enzyme is not fully functional. We have vascular Parkinsonism, where you have small vessels within the areas of the striatum are being blocked. You will have vascular Parkinsonism. And then miscellaneous, you have Huntington's, you have the neurocathetocytosis, among others, and then the normal pressure hydrocephalus. Okay, so there are many causes of Parkinsonism other than Parkinson's disease. Okay, that is a very important point. What are the different?
Thank you, Dr. Mugume. I want to emphasize sorry to interrupt. I wanted to emphasize to the participants that we can send questions, and I've also posted the link to the Neurotorium website. And already we have one question, and to remind you that we have less than 10 minutes to go, 8 minutes to be precise. Thank you.
Yeah. We are finishing. Like I said, there are no laboratory tests to definitely diagnose PD during life. However, a physician must always try to differentiate the different forms of Parkinson's disease, where you look at the different causes, you look at the genetics, and also maybe try to delineate with other neurodegenerative disorders, okay, like the progressive supranuclear palsy, the corticobasal degeneration, and the Lewy body dementia. And from other diseases like the essential tremor, the dystonic tremor, from the tremors that come with Parkinson's disease, okay? And what we need to know is that with the differential diagnosis is that the causes and forms of Parkinsonism are very challenging, especially in the early stages. So you need to be maybe very keen and consult and make it a team approach in doing that. So this is in Wilson's disease, and what we need to know is here this was a brain CT scan, an MRI scan, and as you can see, these are abnormal hyperintensities in the length form. So this and like I said, usually the enzyme that works on the copper is usually very what? It's impaired in chelation of this copper so that it can be excreted. This is another part of the really of the Wilson disease, and these are the Kaiser-Fraser ring in Wilson disease that happen. This one's exactly here. So it helps you to tell to differentiate, okay? And this is for the multiple system atrophy. As you can see here, you see that you have like a hot cross band here, if you remember the hot cross band here, that there. And then we have what we call the progressive supranuclear palsy, where you have like a hummingbird. I've never seen a hummingbird, but this could be the beak, right? Yeah, this is the beak. So if you saw the hummingbird picture, you would relate properly here, but I don't have that much time. So one of the things that we can do in doing our clinical diagnosis, we have bradykinesia. You have to look at bradykinesia and either rigidity or resting tremor. And then these are some of the absolute exclusion criteria. If someone has a supranuclear gaze palsy, if it is only restricted to limbs only for more than 3 years, if you have treated with dopamine, antidopaminergic or with the dopamine depletion agents like our antipsychotics, when there is no response to levodopa, they have sensory cortical loss, and there's no deficiency of dopamine deficiency when you do functional imaging. The red flags you need to look at is the rapid deteriorating of gait, absence of motor symptom progression for over 5 years, early bulbar function, respiratory dysfunction, among others. But to honestly, if you can identify the four cardinal symptoms, that is even way better. That's slowness in movement, the fine tremors, the pill rolling, then they tell you about their cognition, sleep disorders. That should be good enough. And this is the UK Parkinson Society Brain Bank. What it uses it uses bradykinesia and at least either muscular rigidity, rest tremors, and then postural instability with this supportive of unilateral onset, rest tremor present, among others. We have biomarkers. It is still a new venture. We haven't succeeded much, but what we need to know is that much of the damage to the substantia nigra is done before the patient actually presents, and that some of these markers that we are looking in is usually we do like in the CSF, we look at the alpha cyanonuclein, we have the platelet complex 1. These are some of the biomarkers which really help with either identifying, but they are usually not definite, and they are not accurate yet. So the only accurate say that you can do is that you need to try with every levodopa. Usually that is how you can differentiate Parkinsonism from PD. And then of course we can do some imaging, but it might not be necessary in every case, but they're usually very helpful. How you can differentiate it from other causes of Parkinsonism, you usually do the diffusion weighted MRI, which differentiates the PD from Parkinsonism of other causes. The transcranial ultrasonography is coming in to be more handy in some of the studies, but we don't have it here in Uganda. However, it is encouraged. I haven't come across it myself, so I still need to understand exactly. Their burdens, the disease comes with a burden to the patient, especially in their quality of life. The motor symptoms and the non-motor symptoms, such as depression, usually affect these patients more and more. And so it is important to usually take about to monitor that and also to improve their quality of life, but also to look at the treatment-related side effects and complications that come with our treatment or with our making the diagnosis. Some of the neuropsychiatric symptoms, like I said, the depression, anxiety, fatigue, psychosis, usually affect our patients, and so we need to manage them holistically using a multidimensional team. And we have, of course, it also impacts the caregivers in terms of their own health, in terms of modification of habits, how they have to handle the patient, the economic loss that comes, and then the deterioration of quality of life for the caretakers as well. Disability, the disease duration, the costs, the gait impairment, all these affect the care, they have an impact on the caregiver. So we need to always also treat the caregivers. And of course, what we need to keep in mind, like I said, the caregivers, once they're affected, maybe they also affect the treatment strategy that you will have for the patient. And it is also known that usually caregivers of patients with PD usually have the poorest quality of life. And so it is important to always also reconsider them in treating patients and so this is what I was talking about, the biomarkers in the CSF. This should have come before, but it comes now. We have some scales, the Unified Parkinson's Disease, but we have not really used them. And these ones usually look at 4 sections: the non-motor activities of daily living, the motor activities of daily living, if they can eat, dress, hygiene, standing in bed, Then the motor examination, where you look at speech, facial expression, finger taps, toe tapping, and then the motor complications. And they're usually rated from 0 to 4. Then we have the physician administered rating scale, which is usually really to determine the severity of PD, but usually through interaction with the caretakers and the patient, you will know how severe the PD is, but you can use a scale to be very objective. And then among other scales you can use is you have to do the quality of life assessment, the impact scale, which is a 10-item scale. And these are usually physician administered with an exception of a PD questionnaire, which is a self-report instrument. And then we have, of course, doing a mini-mental Parkinson test, which is a mini-form, a non-specific mini-mental state examination, just to see if the patient is oriented, memory, among others that you really assess in the mini-mental state exam. And then you can do a thorough, which is the Montreal cognitive assessment. When they start present with the memory problems, you want to cognitively assess them in their 8 domains of cognitive functioning, okay? And that is the end, ladies and gentlemen. It's been a pleasure presenting to you.
Thank you, Dr. Mugume, for the detailed presentation. You managed to put a lot of information in those few slides, and we greatly appreciate. And thanks also for using your time promptly. So we have 2 questions so far. One is from Dr. Mose Muhammad. Thank you, Dr. Muhammad, for always paying attention and always attending these sessions. The question is, what are the most clinically significant aspects of the Parkinson's disease that clinicians must understand to accurately recognize the condition early, differentiate it from other movement disorders, and anticipate its growing global burden? Over to you, Dr. Mugume.
Thank you, Dr. Musa. You always have very cumbersome questions for the last 5 weeks, but I appreciate you always coming off this hard. So in response to your question, the major clinical symptoms that you need to look out for are the cardinal symptoms of Parkinson's disease. But as we have seen that in the early stages, in the early prodromal stages, these patients don't have motor symptoms. They have non-motor symptoms, okay? They have depression, they have insomnia, they have the REM sleep behavior disorders, they have constipation. Those are some of the early symptoms that you have, okay? Then in the first stage or in the early stage that you will see, you have bradykinesia, you have rigidity, cogwheel, or lead pipe, depending on patients will present differently. And then you have usually postural instability or gait impairment will come later, okay? But the major that you need to look out for are the bradykinesia, the rigidity, as well as the other one, which just slipped in my mind, okay? So those are the major that you need to focus on. However, when you focus on those, you might miss out on the neuropsychiatric symptoms that usually come earlier than the motor symptoms, okay? So it is more of a holistic approach that if the patient is where early has this psychiatric manifestation, you need to work together as a team rather than in silos, okay? And another question I know it was asking about why should a psychiatric nurse or a psychiatrist be concerned with Parkinson's disease, okay? So one of the things that a psychiatrist should be concerned, a psychiatric nurse should be concerned is that Parkinson's disease is a neurodegenerative disorder within DSM-5, and it also comes with the neurocognitive problems, okay? You have memory loss, you have cognition coming in, and these are some of the things that maybe we might overlook when we meet patients with Parkinson's disease, okay? And from our biopsychosocial model, When you meet such a patient, you want to address the biological, yes, you will give the levodopa, maybe the physician will give the levodopa, but then they have the social and the psychiatric. You having Parkinson's disease does not excuse you from having what? Having depression, having psychosis, having bipolar, having these major and minor neurocognitive disorders. So that's why a psychiatrist or a psychiatric nurse should be concerned every time you see have what? Because earlier on, when you even look in the history, Dr. James Parkinson did not think that Parkinson's disease affects the mind of individuals with Parkinson's disease. But Charcot later came and challenged that and said, no, actually these patients present with psychiatric and other non-motor symptoms before the motor symptoms come in. Thank you very much.
Thank you, Dr. Mugume, for handling both questions. I think the people who asked have been satisfied. So our take home is the triad. We should not forget the Parkinson's triad, the tremor, rigidity, and bradykinesia. Dr. Mugume has echoed and re-echoed it. And he has also told us about the other non-motor symptoms we should look out for, especially in the prodromal phase. But there's also a challenge, the red flags, which will show us it's not Parkinson's. For example, if somebody doesn't respond well to the levodopa, usually with actual Parkinson's, there's a very good response. It's robust. But if it's poor or there's no response, we look out for something else. Plus others like the frequent falls, which are usually late in Parkinson's, but if they come early in the disease, it may point to another diagnosis, maybe a palsy, and so on. Thank you, Dr. Mugume. I hereby invite our content experts. I appreciate the faculty members who usually tune in and attend these sessions. We really appreciate having you on board. Today I saw Dr. Virabwa, Harriet. We also have Dr. Mwesiga Emmanuel, and I invite him to give us some remarks before we close. Thank you very much. And thank you, Raymond.
Okay, thank you. I would like to start by thanking, I think the two questions are sort of like important and they are linked and it's really why we have this series. We need to move away from the idea of managing patients when they come. I think we need to start thinking and we've sort of like mentioned it a lot, early intervention. How do we identify patients early? How do we deal with symptoms early? So I was actually surprised that I'd forgotten the issue of constipation. So when I was answering, I think I failed that question. But it's these things that are important because, you know, if you're a psychiatric nurse and you see somebody in their 50s having their first episode of depression or insomnia, and usually we'll say, oh, the economy is hard, or there's a problem with money and things like that. But I think today's presentation tells us that there are many more things that we should think about. And for me, I think that's my biggest take home, that 15 years before, 15 years before you're getting motor symptoms, you're having issues with sleep, you're having behavioral symptoms, and then unfortunately, like there are not that many good treatments for Parkinson's disease at the moment. That's one. I think then the second thing is for people who are interested in research, and it's important that we have to recognize that these diseases are across the spectrum, and we need to start maybe being a bit broader in the patients we recruit. Because, for example, if you're an SHO and you want to do a study on Parkinson's disease, most likely you would look for the patients with the motor symptoms. But I don't know if we have tried to look at studies with the in the prodrome, non-motor symptoms, cognitive symptoms, things like that. So I think this is very. I'm interested tomorrow to learn more about the neurobiology. I'm really interested in constipation because it's something that we rarely ask about. So I think take home is, let's move away from mortality as or disability as one of our key issues. Let's look at early intervention, doing things earlier, doing things better. Yes, we might not have the best treatments now, but if we do, then at least we can prepare people, we can give them information and things like that. So thank you for this. I've really enjoyed it. Thank you.
Thank you very much, Dr. Mwesiga, for that insight. And thank you all participants for logging on and participating. Unless there are more questions, I think we can call it an evening.
Amy,
Please log in.
did you tell them that the presentations are now on the YouTube?
Okay, I can remind them
okay.
that the presentations are now available. The recordings are available on YouTube starting from the last week. And so you can always access them in case you miss a bit of the presentation. So unless we have any other questions, this marks the end of our discussion today. Good night.